So our topic today is evaluation management coding. Okay, so we all know evaluation management is part of specialty. It's a first specialty in the medical coding in RCM cycle, especially in the coding vertical. So which will start all set of analysis, diagnosis, and detailing, thinking, assessing, and doing the plan. Okay, so that this becomes an initial step, or we can tell it, and it is a beginning. Okay, uh, of the process started in the hospital. So after the pre-registration, after the registration approval, so we will be assigned to an physician, okay, who we call it as an referring doctor. Okay, so from the referring doctor, where you will be doing all type of analyzations, and you will be collecting the informations regarding to the patient, which we call it as chief complaint. Through the chief complaint, you will be having a different set of assessment and planning to treat and diagnose the patient. Okay, so this is what the first step we used to do in the E&M, and its main purpose, based on the person's complexity of the disease or complexity of the diagnosis, we are intend to append the codes, which are level codes, which will be following through two methods, which we'll be discussing further. One is a time method, and other one is a MDM table method. To these two pathways, we used to arrive the level of the codes, and through the level of the codes, the payment will be given. And here we do have different place of services. When it comes for the E&M, we start with the place of services. That will be the beginning one. Through the place of services only, we'll be able to move further, okay, which we'll be discussing on step-by-step process. Next, what we are discussing on is like guidelines. So till 2021, we had a different set of guidelines where we'll be focusing on elements such as history, physical exam, medical decision making, and we had ROS, okay, review of the system, and physical examination. So each these elements had different set of points where we have to collectively calculate everything, and we have to bring to the level. But after 2021 and 2023, where thus that complete burden is being reduced, and they made this all complete elements into three main elements, which is called COPA, data, and risk, which we'll be discussing in further. Okay, see, out of these three factors, out of these three elements, any two should be met. Based on that, we will be picking the level. And as I told, we had a two path, which is one is time based, the other one is table based. Time based is very simple and straightforward, okay, which we need to follow few steps, which is very mandatory to arrive the levels. But when you get in now both table related elements as well as the time, we always give preference for the time. Okay, the description of the CPT for both the new patient and for the established patient, where we'll be having the time based code, simultaneously we'll have the level based code, where we'll be picking the codes based on the time as well as the based on the table. But as I said, the priority will be given time based, because time based is one thing, it is going to be very easy, and same time it is going to be very straightforward, and additionally it will not give you the confusion which hierarchy, which level need to be picked. So you can go very straightforward based on the time. Okay, this is one part. These are some of the examples for the new patient and established patient codes, which we'll be seeing in the E&M. Okay, now I was talking some term called new patient and established patient. What is it? And what is place of service? Why we need to have the place of service in the E&M? Okay, so basically to arrive the code, okay, especially when it comes for the E&M, in E&M we do have the different set of subspecialties, starting from the outpatient or office visit, inpatient, consultation, observation, neonatal care, skilled nurse care, okay, then emergency department, critical care or urgent care. So there are different set of subspecialties which will be coming under the evaluation and management. If you ask me very precisely, under the E&M only, all the specialties are coming. Not only like whatever the specialties I have listed out, apart from this, even the diagnostic radiology, surgery, IVR, whatever the other specialty like pathology, medicine, everything is going to come under the E&M only, where it has been separately segregated, and we had a different guidelines for those. Same way we have for the E&M as well. So as I told, for arrive the codes on the E&M, we need to set an main rule when you are going to code based on the table. The first thing is place of service. So it is very mandatory to identify the place of service, because just by the vocabularies which you see in the documentation, we cannot conclude that is going to be the certain place of services. Say, for example, in the emergency service, a ED patient. So here the ED term is also coming, and the evolution management term also coming. What people confuse is like, okay, this is going to be ENM. Or people who are with expertise with ED, they may think it is an ED. So by just keeping the terms, we cannot come to the conclusion. We have to look into the whole scenario to understand whether it is outpatient or inpatient, or in the outpatient, whether it is a new patient or established patient. This is a differentiation we have to bring. So first, I need to identify what is a place of service. Based on the place of service only, you can go for the next step, that is visit. Whether if it is an outpatient, whether it is a new patient or outpatient established patient, or if it is inpatient, means whether it is an initial encounter or subsequent encounter. Likewise, you may get different set of visit depending on the place of services. So first is the place of service, the second is the type of visit, and third comes the table. Okay, now based on the table we are going to arrive, and based on the table weightage we are going to arrive and upon the codes what level and what basis of the elements. Okay, so now we first will go for the first step, that is like difference between the new patient and the established patient. So we have certain rules to come to the conclusion for what is a new patient and what is the established patient. So very simply, there are certain criteria which we need to come across. When it comes for the new patient, we need to check. The first thing is like the service should be face-to-face service. Why? Because we have the other set of service which they provided through the audio and or video. Okay, there is a set of services we will be seeing in the end of the slides, which will be telling you about the telehealth. Completely it is a telehealth services. Here it is face-to-face service, which I have to go to the physically, I have to go to the physician office, or I have to go to the hospital to do complete diagnosis process. That is the first thing. And second thing is like from any provider in the same specialty or subspecialty. Okay, so it is like in simple, I can tell you, we have to keep 3 years rule. First, when I go to the hospital, we keep in a small example, X hospital. When I go to the X hospital first time, I am going to be the new patient. Okay. Now, after 1 year, say for example, for the X hospital, I have gone first time because I am becoming the new patient. After 1 year, say for example, 2027, I'm going for the same hospital for the same specialty. If I go for the same specialty, now I become an established patient in 2027. In 2028 also, I'm going to the same specialty. We'll keep an example, X hospital, cardiology specialty. First time in the 2026, I'm going to the cardiology hospital, cardiology specialty. In the X hospital, I am the new patient. In 2027 also, I'm going to the cardiology. Now I became the established patient. Now 2028 also, I'm going to the same cardiology department. I'm again becoming the established patient. 2029, again, I'm going to the same X hospital for the cardiology department. Now I'm going to become a new patient. So there is a two chances. One is first time when you go to the hospital, otherwise for the same specialty after 3 years. These are the two chances where you get a new patient. There is one more chances also. Say for example, 2026, you are gone for the cardiology department. In 2027, you are going for the nephrology department. Now the specialty is getting changed. The entire specialty is getting changed. Again, you are going to become the new patient in the same X hospital. Okay, because of the specialty, we are going to differ in the visit. So when I go for the same specialty for the 3 years, I am the established patient apart from the first time. Okay, if I in the same 3 years, if I go for the different specialties or subspecialties, I am going to become the new patient again and again within the 3 years. Okay, this is the main core. If you're able to understand this, we are going to be good in arriving the codes for new patient and established patient. Luckily and fortunately, when it comes for the exam point of view, 99.9% is going to give very clearly the documentation stating he is an established patient or he is a new patient in the beginning of the scenario, in the beginning of the question itself. So we need not to be worried so much. Okay, so the second thing is like, as I told, established patient, where the patient is coming for the same specialty within the 3 year or same subspecialty within the 3 year, he becomes the established patient. Okay, that is a 3 set of rules. One is face to face, and second is like your same specialty, and third is like within the 3 years of time span. Okay, that is going to be make you sure whether he is a new patient or established patient. So here is a flow chart to make it a little more clear, to make sure the understanding a new patient, established the patient better, to arrive the codes very easily. Okay, so here is a tree. So when I come to the hospital within the last 3 years, first time, if If I did not come for the last years, we have to the hospital, I'm the new patient. If I'm coming to within the 3 years, yes, I need to check whether it is exact same specialty or different specialty. If different specialty, I'm going to be the new patient because first time I came to the cardiology, now I'm coming to the nephrology. Then if it is the same specialty, I need to check for that. If it is the same subspecialty in the cardiology and nephrology, we have different set of specialties. Okay, like what is that? Therapies and placement of catheters or ECG department, echo department, different set of subspecialties were there. So depending on that, again, if you go for a different subspecialty, it is going to be the new patient. If he's coming for the same subspecialty, it is going to be the established patient. Okay, this is the major difference on the new patient and the established patient. So next thing is on small examples I have provided. So as I told, this is a 3 years rule. If you see October 2026, 2020, okay, he has come, patient has seen lost, then again he is coming for October 25th, 2023. So the window is still open. One more day is there to complete the 3 years. So I will be considering him as an established patient. When it come for the second example, October 2026, 2020, October 27th, one day crossed, the window is closed. Default is going to become the new patient. So that is what a 3 year rule says for us. And the same practice group. See, first thing, he is coming to the cardiologist for last year, and today he is coming with the Dr. Jones from the same cardiologist department. The physicians are different, but the department is same. So he is going to become the established patient. And multi-specialty clinic. If you see here, initially is coming for to the ex hospital, is coming for the cardiology. Second time is coming for the endocrinology, is going to become the new patient because between the 3 years, he's not coming for the same specialty, he's coming for the different specialty. Okay, same way we have some of the example for the new patient examples. If you see, Sarah has never been to a Brent Creek family practice before. She scheduled an appointment with the Dr. Jones. Default, it is going to be the new patient. Written there after long absence. After 4 years, the second example is telling, after 4 years, is coming to the college department in the Mount View. Again, this is going to be a new patient. Then different specialty with the same large clinic. If you see, Metro Health Clinic is the largest clinic. Initially, the patient is coming for the dermatology. Second time, is coming for the foot pain. Okay, so it is going to be podiatrist for the second time. So it is going to be again the different, different specialty is going to be the same new patient. Now, established patient. So routine checkup. After 6 months back, he has come for the diabetes. Again, he's coming with the same appointment. He's going to be the established patient. So seeing the partner in the same practice. See here, Riverbed Medical is a medical group. Initially, they have seen the Dr. Davis, okay, who had given the primary care physician. Again, in the same department, they are coming and visiting the Dr. Green. Yes, within the year span it is there. So that is going to be the established patient. Seeing the nurse practitioner or physician assistant. Okay, so here also, if you see cardiologist Dr. Wright in the same specialty, they're coming in seeing the nurse practitioner. So he's going to be the established patient again. Okay, so there is a few cases where we'll have the little tricky part. If you see a hospital visit versus office visit, Dr. Henderson, pulmonologist, treats a patient hospital for pneumonia. 2 weeks after discharge, the patient sees the Dr. Henderson in her office for the follow-up. Okay, any idea what would be the visit now? Established, he is going to be new.
Um, Same only, sir.
Yes,
So that is a new established one.
okay, so he is going to be the established patient.
Yes.
Next up, different location from the same practice. So uptown pediatrician as main office and small satellite office in neighbor town. A child seen in the main office last year. This year, parents take him to the satellite office for the sick visit.
This is
So
also established.
same. So he is going to be the established one.
Established one.
And third thing, if you see doctor covering for the other practice, Dr. Carter from the Carter Family Medicine is covering for the weekend at the Main Street Family Care, separate practice. A patient from the Main Street Family Care sees the Dr. Carter during this time. A month later, the same patient decides they like Dr. Carter and schedules an appointment at the regular office, Carter Family Medicine. So first they come for family care, separate practice, and second time for the same hospital, okay, so for the same physician, they're coming for the different office visit. So now it is going to become a new patient visit. Okay.
Yes.
So these are the some of the little tricky one where we need to be little careful. For example, I provided. Okay, here key concept to remember. Okay, addressed. Addressed means a physician need to analyze the patient and evaluate the patient, and he has to come to some diagnosis that is called addressed. Stable versus worsening. Stable something the problem has a lower complexity, worsening something the patient is having the bad health. Okay, prognosis. Okay, we do not know what would be the problem. So they may come with some uncertain problem, and we are not sure what is the progression or what is the development of that particular pain or particular signs or symptom. Okay, that is what called prognosis. Social determination of health. Person who do not have the support or financially is poor, that people are called as social determination of health. We can give so many meaning for that. So simply I'm telling you about, we can think like an homeless person or orphan person. Okay, then so we had seen the first part, which is the time based. Now we are going to see based on the table. So when it come for the based on the table, let me go to the table and give you a small intro on the table, and based on that we'll go one by one. So when it comes for the table, so we have three elements. Hope you are able to see the screen, right? Yes, we're able to see the screen, Guna. Able to
Yes,
see
sir.
the
Yes, sir. Yes, yes.
So when it comes for the table, so this is going to be a little repetitive for you. Still, let me try to give some of the examples so that we'll go move a little faster also, so that we can see the examples as well. So we have three elements: data, sorry, COPA, data, and the risk. So when it comes for the COPA, number and complexity of the problem addressed, and the data is going to be amount and complexity of the data to be reviewed and analyzed. And third is going to be risk of the complication and patient management. So first tells how many number of disease the patient is having, what is the complexity of the patient disease. Okay, that is what a COPA, in short we call it as. Okay, 60% of your table will come to the conclusion if you are good with the COPA. If you're not good with the COPA, if you don't know the pathophysiology of the condition, if you don't know the acuity of the condition, whether it's acute, subacute, or chronic, if you don't understand whether it's stable or worsening or progressive exacerbation, severe exacerbation, if you don't know the acuity of the particular condition, you will not be able to arrive the code as soon as possible, and you will be in complete confusion. So it should be having the basic knowledge and the pathophysiology of the condition is very, very mandatory to arrive the codes from the COPA. And second thing is like data. Data is to whatever the condition you come for, I need to make sure, okay, this is the data I've taken from a different sources, like from the outside sources, from the patient, or through the analyzations of lab materials, or from the examinations, or through the imaging methods. So somehow I need to confirm what is the exact problem you have come with, okay, through the data. Now, how much of data are used, how many numbers of data are used. Based on that, we will be able to arrive the data, which will provide you the 30% of the weightage in the table. And last and final but not the least, which will provide you the 10% of the leading for the code, which is going to be risk, which will tell you what is a next plan, what is a follow-up, what is the main management we can do, whether I can provide a therapy, I can do for the operation or go for the surgery. So something I need to come for the conclusion. The conclusion will be provided from the third table. So these are the three major elements which you will see in the table. And we have the four levels. The first level is completely removed after the 2023, where we have started from following the straightforward, low level, moderate level, and high level. This will tell you for each elements we have different of levels. Say for example, if you see the comparison between the COPA and the data, low level, limited level, moderate, high, extensive. So this is a different level namings which is provided for the MDM table for the different levels in the different elements. Same way you can able to see that in the risk also, low, moderate, high. So something will be, it is similar to the COPA table, but when you compare to the COPA with the, sorry, you compare to the data with the risk, again, the level names will be changed. Okay, that is little mandatory. So it should be always, we need to understand what is limited, what is moderate, and what is extensive. Okay, this is based on this table only. We are going to learn entirely about the E&M today. So coming back to the slide, so whatever the COPA, I have segregated here and I made the separate slide for each and every level. So we'll be discussing the each levels with the examples. So the first thing is like straightforward in the COPA, which is number of complexity and the problem addressed. So what it says is like minimal. Okay, straightforward. What is the requirement? Minimal, one self-limited or minor problem. One self-limited or minor problem. Okay, if you see, I given the two example. One example, minor issue, skin issue, and other one is a suture removal. Okay, minor skin issue. Say for example, any insect is bitten. Okay, now you don't want to go for any treatment. If you leave it as such as your immune response going to treat that, it is not going to be a big problem for you. It will get recovered as soon as possible. Okay, which means like I do not need any prescription drug management. and I do not go for any treatment or operation, something like that, very simply, it will be controlled, which is called self-limited. And you see one more example which I provided is on suture removal. Suture removal means, okay, after the operation, after the wound is completely healed, they'll come to remove the suture. So that is going to be some self-limited criteria, which is very minimal criteria. It is not a big problem. Okay, so that is how we'll be ending up with the minimal criteria. We can go for so many minimal criteria, and we need to be very clear. Self-limited. When I say self-limited, something I need to be able to take care. Okay, that is what self-limited for. Then second thing is like low. In the low, we have three different criteria. Okay, be careful here. They're telling or, they're not telling and. Okay, so two or more self-limited or minor problem or one stable chronic illness. So any one criteria is that it is going to be low level. So if for each I've given one example. If you see for two or more self-limited, as I told, there are different conditions you may encounter with, okay, which will not give you the major problem, where you can go with over-the-counter management, a small, say for example, if I get an headache or runny nose, which I take some treatment from home in my house itself, like applying the what is a balm and using some other tablets or something like that, which is like a over-the-counter management tablets. Okay, something like that. Very minimally, if I go through, that is going to be self-limited. And here, comparing to the previous one, here we need to have two or more. That is very, very mandatory. Two or more self-limited or minor problem. Second is a stable chronic condition. One good example I can tell: BP patient, hypertension or hypotension. People who hang the hypertension, it will be there in their body only. It is not going to disappear, because once you become the hypertension person, it is like some long cascade of pathology process, pathophysiology process. Once you become a hypertension patient, till your death, the hypertension is going to live with you. You do whatever exercise, whatever the treatment, whatever it is going to be with you. Okay. So now, when it is stable, the chronic illness is not going to be a problem. When it becomes complicated, when it becomes progressive, okay, or when it becomes exaggerated, when it becomes worsening, then it becomes a different issues. Now here, it is stable. So one stable chronic condition, which I can tell example as hypertension. The third one is like acute uncomplicated illness. Acute uncomplicated illness. So say for example, I can take one example like from pancreatitis also. Okay, pancreatitis, you may encounter, you have severe pain when you get a pancreatitis first time. Then after second time, third time, and all, you will be able to bear the pain, where you can take some, even you can control with the paracetamol. Okay, even you can take a small rest and you can bring back to the control. And if you see like cirrhosis, or if you see like small conditions like effusions and all, we cannot tell, like swelling or a cough or running nose or sore throat, fever, which will lead you to some of the group of symptoms, which will lead you to the some of the abnormality, or it will may lead you to the some disease, but it will not make it as a complicated, it will not threaten you, it will not be a complicated for you. So such conditions we can consider for the acute uncomplicated illness. Here the tricky part is, when you read a disease name in a documentation, your brain should put that particular disease name in any one of these criteria. That is a tricky part. So to put that in this box, you should be very good with the pathophysiology of that condition. If you know that, automatically you can apply to the particular box. So most of the time when I was handling the people, when I managing the people in the ED, and when it comes for E&M, okay, in the E&M also different subspecialties, people always face one problem when it comes for the COPA. They will not be able to understand the pathophysiology of the condition unless or until the condition is previously encountered. You will not be able to relate that. And not only like just by keeping the name of the disease or disorder, you can put it in some box. We should be understanding the entire documentation, the purpose of the visit, and we need to analyze, and we need to bring it to the proper appropriate COPA level. Otherwise, what happens if you do a small mistake, it will affect the other elements in other levels. So as I told, 60% of the weightage I would give for the COPA always. Okay, so these are the three different categories, in the low level. Next, we are going to see about moderate complexity. In moderate complexity, we do have five different complexities here. Okay, so first one is one or more chronic illness with exaggeration. That is what very important. Previously, we have seen chronic illness. There is no doubt in that. But here we are seeing with exaggeration, progression, or side effect of the treatment. When I say one or more chronic illness, already we have seen one chronic illness, hypertension. We'll take one more chronic illness, diabetes mellitus. When it is in the level, proper level, I'm well and good. When it is increased, When I say exaberation means it is not under the control, which means it is keep on growing, it is keep on increasing. That is what called exaberation. Progression, yes, it is keep on improving. The level is getting keep on improving. Because of that, what happens? What is the side effect? You may get polyurination, thirst, or anxiety, fatigue. So much of different signs and symptoms you may get. Okay, so when you encounter the other side effects because of the particular chronic illness, okay, these all together we can consider for the moderate. Here, one or more than one condition they're talking about. Second is like two or more stable chronic. See there, chronic illness with exaberation. Here, two or more stable chronic illness. That is what they're talking about. The second is like two or more chronic illness. Here again, hypertension and hyperlipidemia are given as an example. Yes, when they're stable, you can go with this particular level. Then undiagnosed new problem. Yes, say for example, you've been diagnosed with a lump or cyst in the breast. Now we are not sure, unable to identify. You may get a pain, mastectomia also you may get. Okay, we're not sure what is the reason for the pain, what would cause this pain. You are not able to diagnose it. Okay, you are not able to diagnose it. You don't know what is the condition. You come to the hospital directly. Say for example, here also I give an example: post-menopausal bleeding. Menopausal is over, but the patient is having bleeding. We're not sure what is the issue. If I go for the analysis only, I will be coming to know what is the main reason for the bleeding. Likewise, so unless or until I do the diagnosis, I will not be able to come to the conclusion what type of condition it is. Such a scenarios we will be keeping under undiagnosed new problem or uncertain prognosis. Okay, the next one is like acute illness with the systemic symptoms. Okay, so acute illness with the systemic symptoms, which means like any condition or any abnormality affecting any particular system. We do have 11 different systems in the anatomy, human anatomy. Any one of the system related symptoms, if you're able to see, and if you have one condition related to those symptoms, which you can categorize under the one acute illness with a symptomatic symptom. If you see the example I provided, patient with the kidney inflammation, that is pyelonephritis, and he is having flank pain, which is related to the inflammation, especially to the kidney, eye fever, which is related to the inflammation, chillness, which is related to the inflammation, nausea and fatigue, which both are related to the kidney condition. Okay, it is not completely related, partially these are related to the kidney condition. So these are some of the supporting documentations. Okay, this will be telling you the patient is having the acute illness with the systematic symptoms. Okay, next one is like acute complicated injury. Okay, here the interesting part is complicated injury. See, there are so many set of injuries are there. When I hit the door, when I smash the door, when I bang the door, or when I cut a finger with a blade or knife while cutting the vegetables or doing some other activities, those will not become the complicated. Complicated means something you lose lot of blood, where your vitals will not be stable. You need immediate attention. You need immediate surgery. So, like kind of situation, we call it as a complicated scenario. Okay, see, patient is a headache, purple nausea, unequal pupil. He had an head injury, loss of consciousness. It is really severe. Head injury alone, fine. But what is the complication is getting? That is going to be under this example. Okay, so this is on the 5 different criteria which you need to check for the moderate level in the COPA table. The next is high. Two things are there. One is like one or more chronic illness with severe exaberation. Previously, we saw only exaberation. Here, severe exaberation. Example, all these failures you can take. Here, if you see conjunctive heart failure, which is decompensated conjunctive heart failure, definitely it is going to lead you for the big consequences. Okay, that is a severe exaberation one we can consider. Then one more thing is like a patient is coming into the emergency department with a crushing substernal chest pain, shortness of breath, and diaphoresis, which means like sweating. Diaphoresis means sweating, which is a critical symptom for the myocardial infarction. In short, we can tell it as heart attack. Okay, though, so there is a possible the patient may get heart attack. That is the reason he is having crushed substernal pain, chest pain, and shortness of breath and diaphoresis. So, which is threatening to your life, amputating your leg due to the fracture, or doing some surgery and removing something, or affecting your entire function and physiology. Okay, this all comes under one acute or chronic illness injury, posing to threaten life and body. So if you see here, one more example I included for the same, that is SODH. Okay, sorry, SDOH. So SDOH, social determination of health. So any patient coming as a social determination of health, default they are going to come for the high. Okay, so this is the step-by-step process we have seen in the level. So as I told, we need to be good enough to know the pathophysiological condition. First, when you read a condition name, you should relate which system it is related to. And at the same time, what would be the signs and symptoms for this? And next thing you need to know about what will be the pathophysiology of this particular condition. These are very, very mandatory things which we need to be able to understand when you see a disease condition or abnormality or disorder or syndrome, whatever it is. Okay. So this is what we are seeing in the COPA table. Next, we will enter into the data table. Same way, we'll see the different complexity in the data table also. Here, what we have is like straightforward. So here what the straightforward says is minimal or none. Either the data will be very minimal or it is going to be none. So none, previous record is not there, test is not there, any independent interpretation is not there, any discussion, nothing is there. Okay, simply is coming, okay, and just is taking in what is it, some what is consultation with the doctor, and doctor is going to tell you like drink a lot of water, or take some moisturizer, or use take rest. Like that, he is going to give you some suggestion for you, and he is not going to review any previous report, not going to order any test, not going to discuss with your referring physician. Nothing is going to do. That is going to be the minimal or none in the data. The second one is like limited, okay, which is like we call it as low complexity data. Here the interesting part is we have a rules, okay, for data, starting from the limited to the moderate, then to the high level. We have the rule for each level. We have a rule, and in each level we have a different category. For the category also we have the rule. Okay, first you see limited must meet requirements of at least one of the two categories, which means out of there will be two categories in the limited, which means low level in the data. We will have the two categories. In that, out of two categories, it has to meet one category. That is a rule for that level. And in that category also, one of this category, we have a rule combination. Okay, they have listed some few things in the down. We need to combine. We need to combine any two combinations should be there to choose the category one. And the second category is like assessment requiring an independent historian. So our mother, father, friends, somebody has to come and tell to the physician what is the problem I am facing. Okay, that is what called as independent historian. Here, the first one, if you see the example, what I provided is like hypertension and hyperlipidemia, two different chronic conditions a patient has come for. Here we have gone with the two different tests, basic metabolic panel and lipid panel. Both are belonging to the ordering of the each unique test. Ordering of the each unique test. So here if you see review of the prior external notes from the each unique sources, review of the results of each unique test, ordering for each unique test. So either it can be one point, like it should be a two combination. It can meet any one point, any 2 point here, or in one main point itself, it can meet two different combinations. Okay, one good example I can tell is like, say for example, ordering for each unique test. That is 1 point, right? In that, if they're ordering for CT and MRI, now it becomes a two combination. That is why they're given the AST symbol. If you see in the left side, right side corner, there is a AST symbol, which means that 1 point you may have different set of review, different set of test, which is also we need to take into account. It is not like first plus two or first plus three or 2 plus 3 like that. We need to have the different combinations. It is something like in one combination, in one sentence itself, different combinations can be there. That is what a category one says. Okay. Here, as I told, ordering for the each unique test, that is the BMP, basic metabolic panel and lipid panel is ordered, which is coming in the category one, and the patient is going to be low, which means like limited level, as per the guidelines which I have told, like out of two, one should be met. Then third one is like moderate complexity of the data. Here, same we have the category 1, 2. Additionally, we will be having one more category. Here also the rule says out of three category, it has to meet any one. Out of three categories, it has to meet any one. The quite interesting part here is like the very important point here, which we need to notice is assessment required an independent historian. If you see here, previously assessment required in an independent historian is a separate category. But here, that category is merged with the category one. That category is merged. The second category from the low level is merged with the category one in the moderate level. Okay, that is what the interesting part here. So here, what is the rule for the category? They're telling in the level, the rule is out of three, one should be met. In the category one, the rule is out of these, three combinations should be there. There are two combination we saw here, three combination. So it can be a combination from a review of the prior external, or review of the result or ordering of the each test, and assessment required for the independent historian. So usually what happens, mostly the cases in the data, when we are encountering the project, when we are taking for acuity report, most of the people, they may like previous month, they may have the uh, moderate level. Suddenly they'll go for the low level when you have the trainee people or freshers in the process. They'll go for the low level. Why? Because the understanding, they may think like this assessment when it is coming in the category 2, they may think like it is a low level. Okay, when there is a two combination is there, and plus when you have the one more category 2 assessment required for independent historian, what the people may think, okay, it belongs to category 1, or they may think, okay, the two categories are meeting, category 1 and 2 is meeting, there is an advantage, so I can go for low level. That is what they're thinking. But actually what happens, that assessment required an independent historian is merged here. In that case, I get a 3 combination, so I should go higher level of coding only, which is like moderate I need to take. People, what is their understanding? They think like, okay, two category it is meeting. Here the interesting point is the second category is merged in the first category of moderate level, so I should go with the moderate level. Okay, there is what a unique one which we will be seeing in the level, this moderate level table in the data. And category 2, independent interpretation of the test. Okay, after performing the test, whatever the data they're collecting or reviewing, they need to interpret whether it is a good or bad, normal, what is the scenario, what is the circumstance you are now currently in. That explanation need to be provided. That's what comes for the independent interpretation. Then comes the discussion of the management or test interpretation. So this is like something I will be discussing with some other physician. Why? What? Who is the external physician here? How I can imagine here means, say for example, if I'm coming to the general physician, okay, family care physician or primary care physician, he has identified there is a stone in my kidney. Okay, now he will take that report. He will take the report and he will do the interpretation with me. Dear patient, you have a so and so problem. So and so thing we need to do. So and so plan we have to do. So and so assessment we have done. Now, apart from that, the physician is going to call some nephrologist and he is going to discuss, saying that Dr. X, I had a patient today who has come with a kidney problem. And when I diagnosed him, he has a kidney stone. So, what is the further step I can go? So, that kind of discussions, if he is going to have, that becomes a discussion of the management or test interpretation. Okay, based on that, I have given some example here. If you see that first a 55 years old new patient with the shortness of breath, he has seen urgent care center yesterday where the chest X-ray and EKG were performed. He brings EKG tray, shows normal sinuses rhythm to no acute ST changes, and radiologist report X-ray everything. So they are the two reports. They have reviewed one report and they have taken the chest report. They have reviewed the external note, and finally they were like EKG were discussed. Okay, interpretation were done. Okay, interpretations were given for the EKG which they already taken. So altogether it is meeting two categories, category 1 and category 2. I'll be going with the moderate in the data. Same way, if you see for the high complexity, same category 1, category 2, and category 3 will be there. Here, the interesting point is like this level as out of three categories, it has to meet two categories. Out of three categories, it has to meet one for moderate. Out of three, it has to meet for the two categories. So, based on that, if you see here, so category 1, independent historian were documented, and a prior external notes were seen, 3 unit tests were documented. So, all these three meets the category 1. And again, when the physician is reviewing with the other doctor regarding to the what is the current patient status, that will become the category that is a discussion of the management. So it will brings you to the code 99205 or 99215 on the end. Okay, so that is the example on the extensive. Then comes the risk table. Okay, in the risk table, the first thing is like minimal. So minimal is something like some bandage, ointment, superficial dressing, okay, elastic band, gargles, and rest. These all kind of suggestions or plans is provided, which are self-limiting issues. The management plan is very simple and observation, and no specific action from the provider need to be provided. Okay, will be given. This all comes under the minimal risk. Okay, then the third one is like low risk. In the low risk, where I may go for a small over-the-counter drug management or other therapies or minor surgeries, okay, without identifying the patient procedure. So, without identifying the patient or procedure risk means they do not know what is the patient problem already is having, whether it's a kidney patient, a kidney failure patient, or whether it's a heart attack patient or diabetes patient. Without knowing that, if I do the minor surgery, that also comes down another low level. Okay, one example what I provided: simple suture removal in the office setting, simple incision and drainage, of very small uncomplicated skin abscess. Then next is like moderate level. Okay, in the moderate level, we'll be having it is like precision of drug management, prescription of drug management, like refilling, starting the new drug, adjusting the drug, decision for minor surgery, decision for the elective major surgery. Okay, so the minor surgery without identifying of the patient. See here, the patient is having uncontrolled diabetes, still they are doing the skin abscess. That is what comes under and I with identified patient or procedure risk. Okay, same way we have SDOH also. When you come for the SDOH, the social determination of health, we can go with the moderate level. Same way, we have the drug therapy management and a decision for the elective major surgery with identified patient risk. Okay, so we know patient is a BP patient or COL patient. Still, I do some kind of surgery that is becoming the decision for elective major surgery with identified patient or procedure risk. This is a decision for emergency major surgery, decision regarding hospitalization who becomes inpatient or observation patient, decision to resuscitate or de-escalate, which is like there is no more, we cannot treat anybody, you can take to the home. Okay, like that they will be telling, right? That is also called resuscitate or de-escalate. Okay, so that also comes under the high level. Okay, so these are the different different set of elements. Okay, different set of elements and different set of levels which you have seen in the data table, POPA table, and in the risk table for the MDM table. Hope you are able to understand. Okay, since you are already ED coder, I'm
Yes.
not giving you stress on this. Okay, so we'll go further and we'll see further slides. What is the basic things we have to see for the exam? So here I've added something called place of service. Yes, sometimes you may get a questions related to the place of service. We'll be encountering, we are looking into the domain wise, in that we'll be seeing the deep. Here for the E&M related, these are the some of the place of services. Then we have deleted old telehealth code. They introduced new telehealth code based on the audio and video for new patient and established patient. And next is like only audio, new patient and established patient. Okay, so these are the codes which are related to the UK medicine based on the table or time we'll be supposed to take for the telehealth coding. Okay, telehealth evaluation and management of the patient. Okay, so this is what a telehealth code. And so some of the modifiers, if you see the modifiers specifically, it come for E&M 24, 25, and 27. 24 unrelated E&M service during the post-operative period. Okay, so it is like firstly initially I'm coming for some surgery. After some days I'm coming for some diagnosis. Okay, so stomach surgery is there, but I got some knee pain. Now I'm coming and checking for the knee pain. So now it becomes the unrelated E&M service during the post-operative period. That go 90 days of global period, whatever the services they're providing, those will be included in the surgery criteria. But this is not related to the surgery. This is different condition. So in that scenario, I need to use for the 24 modifier. 25. Same day, outpatient and ED they are performed. We can use 25 modifiers, separately identifiable E&M service on the same day as the other procedure. Then 27, multiple outpatient E&M encounters on the same day. Okay, same outpatient encounter they might have done different scenarios for different condition. In that scenario, we'll be using 27 modifier. Other modifier are procedural modifiers, specialty care modifier, and laboratory modifier. This maybe you may use along with the E&M when you're doing the coding. But when it comes for the exam point of view, no need to be coded. Okay, so a few of the examples I have added. Okay, so we'll try to see the examples so that it will be little easy for us to understand the documentation. Okay, so the first example what I provided is like uncontrolled hypertension, no new complaints. They have seen the log already, and there is a subjective provider note and objective provider note, then followed by that assessment and plan. In assessment and plan, he has told hypertension, cardinal lipronil, refill the Centos pharmacy BP monitoring, return to the in 6 months. If you see, the COPA, what is here is like chronic illness, something it is very stable. Okay, and what is the data here? We have the prior notes and they have the BP log. Okay, this is all they're verifying, which leads to the two combinations here. And third is like refilling. They're telling the refilling of the drug which comes under the drug management. Okay, based on that, if you see, COPA is low, data is low, and our risk is moderate. Okay, so here chronic illness and a review of the prior notes and BP log low and moderate. So out of three, two is met, So my answer is going to be low level. My answer is low level. The final code is going to be low level. When it come for the time between the 20 to 29 minutes, I can see the low level. Then established patient. So here is it is established patient. That is what 99213. Okay. Here come for diabetes do on CAD and is having right upper quadrant pain and some systemic related conditions also there. Now subjective details provided by the provider note and objective details where they're talking about few things here. First thing is like a chronic condition is there, and foremost importantly, right upper quadrant pain. There is no conclusion. New problem etiology unclear. Differential includes cholecystitis, gastritis, hepatitis. Okay, so that is very mandatory. So if any differential condition is given and still I'm not able to diagnose it, okay, that will become the unprogressed or undiagnosed or unprogressed conditions as per the moderate table. Then the third one is like they're given the lab CPC, CPC, CPM, and lipase. So it meets three different criteria. So I can go for the moderate combination. Okay, so my data is going to be moderate, my COPA is going to be moderate, and my risk is also going to be moderate. Okay. Then here one more example. If you see here, undiagnosed, okay, same. Undiagnosed moderate and unique test CPM and lipase ultrasound they're taken, it comes under the moderate level. And for the prescription of the drug, again, it is also coming under moderate. My output is going to be moderate. Okay, so out of three is moderate. I will be using the moderate. Then comes the I take new patient visit. Okay, here a patient is coming with a CHF, which is like decompensated CHF. You can relate heart failure, respiratory failure, and all to the high level. Okay, so it becomes the high level. So apart from that, independent historian official EKG is there. Discharge summary they have read a decision regarding the hospital, which comes under the risk high table, and discussing an EKG. Okay, and interpretation for that EKG and what is that? Discussing with the patient and the doctor due to the severity symptom hypoxia, patient gets direct admission to the hospital. So this all comes under making the decision with us. This all comes under the high level. Okay, so based on that, you see MDM is high. Yes, data is also high. Same interpretation historian and independent historian interpretation. Then risk is like decision regarding the hospitalization. So this all comes under high. So my data is going to be also my risk is also going to be high. Okay. So these are the some of the examples which you have seen, okay, for the different scenarios, okay. So we do not have anything additional in the E&M. So when you encounter the documentation, that will be easy if you are not able to understand. So which we need to again see the table and understand where we are losing and where we are not following correctly. Okay. So far you understood, right, Bruno?
Yes, sir. Yes, sir.
Okay. Now we'll go for